Welcome. This is another one of the Psychology for You lectures, and this is the fifth one this year. And just a couple of housekeeping things before we start. We're going to have another lecture in June, on June the 6th, and I thought I'd tell you about that. It's called Sending Kids to Camp, What to Know and How to Prepare. So if you're going to send your kids off to summer camp, that'd be a good one for you to come to. Also, at the back of the room here is the outline for the session tonight. And I understand that this will be available in the near future at the other centers that are watching at a distance tonight. We're very fortunate. We have 11 other centers all across Nova Scotia watching the session tonight, so that's great. And we're very pleased to offer this service to the public. Tonight, we're very fortunate to have Dr. Byrne come and speak to us about ADHD, and his talk is ADHD Beyond the Headlines. Dr. Byrne is the Chief of Psychology at the IWK. He's been here for 23 years and has seen numerous patients with a wide variety of problems. Included, of course, are many individuals with attention deficit hyperactivity disorder. He's also conducted quite a lot of research in a variety of areas, including research on ADHD, especially with the preschool population, which is an under-neglected area of evaluation and treatment. So please welcome Dr. Byrne, who will be giving the lecture.
Thanks. That was Dr. Harry Bodden, who's with the psychology department as well. Tonight I'm going to talk about ADHD, but try to take a little bit of a different orientation. Most of you have probably been to a variety of talks, as I have, on this topic. There are numerous presentations. And I'm not going to get into the nitty-gritty of evaluating whether we're looking at 4 points on a checklist or 5, etc. I just want to really sort of get us to draw back a little bit and talk a little bit more conceptually about the issue of the diagnoses and about treatment. So it'll be a little bit different than what sometimes people do get at these talks. Essentially, I'm not going to do an entire review of the area, but certainly open to lots of questions that you may have about the diagnosis and treatment. The issue I want to address tonight is more or less trying to look at misconceptions or misinformation and some misunderstandings about the diagnoses. Most of you, if you actually tapped into a Google search on ADHD, you could spend probably about 3 weeks going through the first 3,000 hits. There's no shortage of opinion and commentary out there, mixed in also with the science. And so I'm hopeful that tonight we can talk a little bit about separating a little bit from the science from the opinion. It doesn't mean that we have all the answers by any stretch. I just want to make sure that we do have a little bit of a broad understanding and a balanced view about the diagnosis and treatment of attention disorder. Basically, when we talk about attention disorder, we're talking about 3 major areas of functioning or dysfunctioning. The first, dealing with inattention. Well, that makes a lot of sense. Individuals who have significant problems with attention and focus on a variety of tasks. Individuals who are fairly impulsive, the usual sort of, didn't think before talking, speaking, moved before they shouldn't have moved, and so forth, have difficulty actually sort of inhibiting their response, whether it's behaviorally moving somewhere, running around, or whether it's actually talking. And hyperactivity, that's the area where most of us are fairly familiar with, which is kids, usually kids running around, crawling along the floor or the wall or whichever. And actually that's an important area to think about, because the problem a little bit we have, I think, is that when we talk about attention deficit hyperactivity disorder, where our first experience with the diagnosis is with the hyperactivity aspect of it. And when that's our first experience, but we kind of keep that concept in the back of our minds. And I think that we sometimes over-focus on the hyperactivity aspect of it, such that at a later point in time, people assume that since the hyperactivity has kind of died down a little bit, therefore the diagnosis has gone away. And we'll talk a little bit about that today. So your first experience is usually with the young child, 4 or 5, who's extremely active relative to his or her peer group. And so we sort of have an idea, we know what hyperactivity is. That's true enough, but the problem is that the form of attention disorder can change over time. And we'll talk a little bit about that today. The headlines are many. Send your kids outside now. This is based on an article that was at the USA Today newspaper March of this year. Researchers are believing that outdoor play can be an effective treatment for ADHD. Well, no question that having kids active and actually having their activity corralled and channeled in the right forum is a good idea. There's a problem with suggesting that that actually is a treatment for the disorder. In fact, there's no research to suggest that. Many of you are probably very familiar with the recent news coming from the federal agencies in the United States, talking about ADHD drugs for kids and then talking about hallucinations and so forth. Very important area. The only a couple of comments I want to make. First of all, anytime I talk about medications here tonight, I'm talking as a non-physician. The only persons actually who are appropriate to be talking about with you or with someone you know about medication is a physician. Okay? I'm just simply giving you some commentary as based on the psychological literature and so forth about medications. But if you have issues with medication, it's the physician you should be talking to. The only comment I would make about this is that when you've got these reports coming out of the United States, there's a huge number of individuals who each year are diagnosed with attention disorder. A number of them are actually put on medication. It's a very large number, both in Canada and the United States. And there's a small number of individuals who have been affected and actually report some of these difficulties. It's not to suggest that those small numbers are insignificant, but it's important to note that when you look at some of these studies, you find out that there's a lot of differences in age, there's a difference in dosage and so forth with medications, and many of these kids may have a lot more than just one medication there. You hear about Ritalin, you may find out that child is on 2 or 3 other medications. So you have to be very careful when you're going through the literature, when you're going through asking some questions about the headlines that are in the news about Ritalin and attention disorder. I guess the general comment we've made is that anytime you get into these kind of medications and you're dealing with fairly high dosages, it's not unexpected that you may have some side effects such as difficulties with your, cognition. You may have sort of psychotic episodes, or you could have some challenges with keeping your focus on your thoughts and so forth. So that's when you're dealing with fairly high dosages. It is also the case that some individuals, a small number, actually may have an adverse reaction to these kind of medications. Again, you need to talk with your physician about that. It may well be there may be a small group of individuals who have particular markers that would suggest they are not a good candidate for medication. But we're dealing with a small number of individuals, and again, your physician is the one to talk to about these issues. Recently in New Brunswick, this year even alone, again, we talk about Ritalin. We've got to do something about it, so the New Brunswick Ombudsman fears Ritalin being overprescribed. It's okay to be aware of these things and cautious. It's just a bit of a problem when they start throwing these headlines out, and then everybody gets in a bit of a panic. And we can talk a little bit later on about what actually drives these headlines. And if you understand actually how prescriptions are made, you'll find that actually that the estimates of how many individuals are taking medication are quite different than implied. We're just ahead of the game. It is 2005, exactly. Thank you. Yeah. This will be in the Globe and Mail, I guess. It's yeah. They don't report the news; they make the news. Food additives is a hot area, of course. There was a study that came out, reported back in 2004, suggesting that 3-year-olds were markedly more active, inattentive, and short-tempered when fed a diet heavy in food additives. Well, I don't think too many people would have trouble with understanding that kind of link. The question is really, does a heavy diet like that, is that a characteristic diet, first of all? And also, if that is the diet, how many kids does that really make a difference for? And does that really cause a full-blown diagnosis or symptoms to make you into diagnosing an individual with attention disorder? We'll talk a little bit later about the evidence to support the issue of diet and ADHD. Removing tonsils, linked to cure for ADHD. Well, it may well be the case that individuals who have very poor sleep because of sleep apnea related to some kind of obstruction certainly may be more restless, irritable, and difficult to manage. But again, to suggest that that is the causal link for attention disorder in a large number of individuals is probably fairly misleading. Again, it's the idea of you could have a small ounce of link there, but in truth, you have to actually dissect it a little bit before making some firm conclusions. They make great headlines, but they don't make great science and understanding. The link with treatment of exercise with ADHD has been out there for quite some time, and there's some studies that go in and talk about working with different types of exercises, daily balance, hand-eye coordination exercises that improve focus. And it's a program not just for kids with attention disorder, but also dyslexia and other learning disorders. So it's a fairly impressive program that they have put together. I think the issue is that, again, is that it's probably good that you have individuals who are helping children to stay focused. The activities themselves may help them to stay focused at some point. But again, making a link that this actually makes a significant change in a diagnostic presentation of kids is just not supported by the research. The bottom line is that almost all of us exhibit or have exhibited one or more features of ADHD one time or another. Okay? Maybe some of you may feel not the case, but the vast majority of us have. I certainly have. One has trouble focusing at times. You're trying to do 3 or 4 things at once. You can be pretty active. You can be a little bit hyped, anxious, etc. Most people can find 1 or 2 symptoms here and there or more at certain points in time. That ADHD is really more or less a continuum, and that's the point to start thinking about here, is that everybody has some periods of inattention, everybody has some periods of overactivity, et cetera, and distractibility. But what separates the person who has that on an intermittent basis from someone who actually has a disorder is the magnitude of those experiences, the frequency of them, the difficulties that they have in actually trying to pull back. So the inhibition, can't quite hold back, want to do something, want to say something, can't actually pull back when they know better. Okay? They don't know when to quit, for example. So individuals who actually have ADHD, they're like everybody else, but we're just moved a little bit further on a continuum. We have difficulty staying focused, having difficulty controlling inhibition. As far as the prevalence rate of ADHD, it's quite variable and depends on what literature you look at. The figures I'll throw out here are sort of average, in a sense, over a large number of studies. And we'll talk about later. It depends on the study cutoffs that they use, the criteria they use, the different types of measures they use in a variety of studies. So depending on what kind of measures people use, you can have changes or differences between one study and another in terms of the number of individuals diagnosed. Okay? So don't be alarmed when you see a study come out and say there's 12% of kids who actually have attention disorder. Another one says 18% or 20%. Remember the fact that it may be varied to some degree because of the different type of criteria that someone used at that point in time for that study. Okay? The variability of estimates has been used by some individuals to say, well, see, there you go. There's so much variability. How can it possibly be a disorder? I think the point's well taken is that if there's a huge discrepancy, then there are some issues of measurement, but that doesn't actually suggest that there isn't a disorder there. There may be some variations in how we diagnose or what cutoff scores we use to decide this child is moved beyond the normal range of hyperactivity, normal range of inattention. But basically in the 6 to 11 year range, kids, about 3.5% of individuals may have attention disorder with a learning disability. We'll talk about that a little bit later. And about 3.33% or so kids who actually may have attention disorder by itself. This is a bit of a complex figure, but it's from the Center for Disease Control. But just sort of concentrate, look here on that left-hand side for a second. And this is for male and female. Okay? And basically, if we look along the side here, the left-hand side, we have the age groups. So it goes from age 4, 5, 6, 7, right up to age 17. Okay? And then we look at the actual magnitude here, the number of individuals involved here. Okay? And the heavier shaded area, which is the, I guess it comes off here, is somewhat sort of a darker purple or blue. This basically refers to individuals who've had, at some point in time, been diagnosed with attention disorder and are taking medication. Okay? And this is an important figure to keep an eye on because, as we'll talk about later, there's a lot of individuals who may start on medication and do not continue on medications. Okay? And the lighter shaded area refers to individuals who've been diagnosed but are currently not taking medication. Okay? And so what you can see there's quite a gap between those who have been diagnosed and are medicated currently and those who have been diagnosed and are no longer medicated. Right? So it's important to keep this in mind because there's oftentimes a misperception that, gee, we need to hold off as long as we can before putting a child on medication because once they're on for good. Okay? That's not accurate at all. In fact, as we'll talk about a bit later on, if you look at the statistics, many individuals stay on no more than 18 to 24 months or so, on average. There are individuals who have more severe symptoms and so forth, but it's amazing how many individuals start out and then pull back on their own. I'm not saying that they may not, I'm not saying that they wouldn't benefit from continuing on the medication, just simply the fact that the pattern is that many individuals stay on about a 2-year period. You don't hear about that in the press. All you hear about is that the number of individuals who've just got new prescriptions and so forth. But in actual fact, there's a large percentage of individuals who do not stay on the medications.
Are there stats? Do you mind if we ask?
Sure.
Are there stats that, like, children or people who never took any medication?
Sure. Yeah, we can go into that a little bit later on. There's, it varies about where you are and where location, whether in the United States or in Canada, and different provinces and so forth. But on average, there's about 50% of kids who may have a diagnosis may not go on medication. Having a diagnosis doesn't mean you need to go on medication. That'll be a point made a little bit later on here. So what I want to do is just address some of the myths a little bit here. Just maybe we can just formulate a little bit of discussion. The first one that's come out from a lot of folks is to suggest that ADHD is not a real disorder. Well, in fact, it is a real disorder. It's a neurobiological disorder. It's developmental in nature, meaning that it starts early in life and it can continue on for a certain percentage of individuals. There have been numerous studies showing that there's a significant genetic predisposition to having this disorder. And so that basically it's no different than having other types of disorders, that their genetics plays a pretty heavy role, and it does for this as well. Genetics is heavily involved in eye color, your hair color, your teeth, or whatever. Well, it's also involved in whether you have a higher probability of having vulnerability to developing attention disorder, genetics involved in whether you have significant cholesterol issues and so forth. Genetics is genetics, and this is no different. So there is a genetic predisposition for ADHD. Numerous brain imaging studies have actually confirmed that there are significant differences between individuals who have properly diagnosed ADHD and those who do not. And by and large, many of the studies are looking predominantly at the front part of the brain, or the frontal area, which is sometimes thought as holding the area of what we call executive function. Executive function in the front part of the brain is dealing with things like decision making, being able to shift from one activity to another, or shifting solutions and so forth. It has a lot to play, and decisions about what to pull out from memory and so forth. It has a lot to do with staying focused and maintained on a particular task. So it's not surprising, therefore, to suggest that people who have that difficulty and show it behaviorally, the brain studies, generally speaking, show that the frontal part of the brain, known to be linked to that ability to focus and make decisions, is different in individuals who have attention disorder versus not. Initially, there were some studies that suggesting that the problem really is that there's lower blood flow in the front part of the brain. Well, indeed, that's true, but when they dig down a little bit further, it's actually the fact that there's a difference in the amount of electrical activity that's going on in the front part of the brain. Okay? So our brain is functioning, firing all the time, so there's lots of electrical activity going on. But the front part of the brain, we find is that individuals who have attention disorder may have a lower amount of electrical activity. Cortical evoked potentials are recorded. They're having lower amount of activity there. When you have lower amount of activity, you also have a lower amount of blood flow that's going into that brain area as well. So again, what we're simply trying to suggest to you is that like many other types of disorders, there are data from brain imaging and other studies that actually show there are differences between individuals with diagnosis of attention disorder and those without. ADHD is caused by ineffective parenting. And if any of you are parents, you've probably heard that, or if you haven't heard it, you probably get a look or two from various people. The essential issue here is that ADHD is a real disorder. It can be lifelong for a certain subset of kids. It depends on the study you look at, and we'll talk about this later. Anywhere up to 70% of individuals may retain symptoms of attention disorder from childhood right on through. So you could have, for example, you have a highly hyperactive, impulsive, say 5, 6-year-old, upwards anywhere from 60 to 70% of those kids will go on and show that, continue to show those symptoms into adolescence. Then 60 to 70% of those individuals as adolescents may go on to show that in adulthood. So you have roughly about a 35% continuity. If you're looking at a 6-year-old, there's about a 35% chance they may go on right into adulthood to present with those symptoms. It doesn't mean that actually people go on and keep treating the disorder at that point in time. We'll talk about that. As people get a little bit older, they decide to make different decisions about how they want to manage their symptoms. Anywhere about 2 to 6% of adults have ADHD, and actually that number is changing probably in the last 5, 6 years. I know certainly myself and other individuals in this and other communities have gotten a remarkable increase in the number of referrals from physicians and other individuals and self-referrals from adults who now at 30 years or older have decided, gee, I seem to have a problem here. Sometimes that's prompted by the fact that their child has been in to see somebody, and they're getting a sense that actually the child's behavior is not a whole lot different from their own, and when they chat with their mom or someone else, they say, gee, he's pretty much like you when you were that age. And so there's some tendency for people to be looking at that at this point in time. And we'll talk about that. It's not a childhood disorder, even though that's where the predominant amount of work has been done. ADHD is not a childhood disorder per se. The first occurrence of it predominantly is in childhood, but that doesn't mean it belongs to childhood. If there's any one area that actually has got a lot of press, it's the issue of ADHD being caused by sugar, food additives, and so forth. There's not a lot of evidence to strongly support the connection between the diet and ADHD. It depends on what study you look at. You will or will not find a causal link. The important thing to make sure is that you find out who's sponsoring those kinds of studies, just as the fact is that if you're looking at a study with an effective drug, to make sure who's sponsoring that as well. So I'm not taking one side or the other. What you want to understand is who may have some secondary gain when some of these studies are done. Basically, it was interesting when I was doing a Google search there yesterday, and I just wanted to hook up with, find out about dietary issues and anything new with Russell Barkley, who's a well-known international expert on attention disorder. It's interesting, a number of websites are creatively put together such that you think you're actually hitting one of his websites when in actual fact you're going to another one. And then you get this commentary, and you're not quite clear till you get very to the end, you find out actually who's actually written the article. Okay? So again, be careful about what you're looking at when you look through the websites and other areas. You should be looking for information, but be a little bit aware of where it's coming from. But there have been a number of studies conducted, and generally speaking, what you find is that indeed food additives can be an issue. Many people are interpreting the fact that food additives and heavy fatty diets and others so forth are more or less can be, in some percentage of kids, can actually increase already existing symptoms. It's not that you suddenly go from a child who's got no symptoms of attentional problem, and suddenly now with the diet, you actually have a shift in an entire profile of the behavior such that you now meet criteria for attention deficit disorder. Some of the studies would suggest about less than 2% of kids will actually show a rather significant difference in their behavior on restricted diet versus not. Okay? And that's it's a large number of kids when you look at it across the entire population of North America, so it's not to be discarded, but it's not clear who that 2% may be. Many of the studies also have been done have not actually monitored closely the diets. One of the best studies was done in Canada by Bonnie Kaplan back in 89, 90. She's at the University of Calgary. And they actually had a large grant where they studied families, and they actually, over a period of several months, had all the food prepared for the families, all 3 meals a day. Food was taken in, out of the house, checked, rechecked, and so forth. And in that study, they did find some effect of the diet. It wasn't a large effect, and it affected a small percentage of kids. But again, affecting it, magnifying the behavior in some individuals, it doesn't necessarily mean that that is the link or the positive cause driving the actual diagnosis of attention disorder. I mean, some of you also probably find as well is that you say, gee whiz, I shouldn't have given that chocolate bar. Look at him now. Well, if you actually went back 5 minutes ago, you might remember that you gave him the chocolate bar because he was bouncing all over the place. So there are also, when you have those anecdotes of saying, well, it's the sugar, it's the caffeine, it's the chocolate, and so forth, you need to look at what the behavior is like prior to either adding or taking away those kinds of those foods. ADHD is overdiagnosed. Well, I put a mark on that and said no, but we need to talk about that. The prevalence rates, as I say, vary greatly from one study to the next. You have cutoff scores, different measures and criteria used across studies. What you've seen in the past number of years when people talk about how there's been a major shift over the last several decades in the number of kids identified, you had to keep in mind, too, that the actual diagnostic criteria has also shifted here. The inattentive type, which is a separate type of attention disorder, was added back. We moved from the DSM-3, then DSM-3R, and now to DSM-4, and the 5 should be coming out the next year or two. And basically, the inattentive type actually has added on a dimension that previously was not. The attentive type meaning that the child is not the one, or the adult or adolescent is not the one bouncing around and overly active and so forth. It's the individual who's sitting there, calm, collective, and looking, and is just not processing much that's going on. They're thinking about the baseball game, they're thinking about something else, they're sort of thinking of the future, thinking of the past, but not any kind of attention to the present. They're never quite in the present. And so the inattentive type is a group of individuals who have been left alone until there's been a change in the diagnostic system. And so part of that actually has increased the diagnoses. The other part, too, is that, not so much here, but in the U.S., there's legislation that actually is to assist individuals in requiring states to actually help individuals who have disabilities. Attention disorder is listed amongst those. And so when that came through in the 90s, there has been a major shift there. So there's set criteria, and so individuals may actually be diagnosed to fit into particular types of programs. There may be an increase in diagnoses in order to fit now a program of treatment that's offered. So you have to be aware of just the general environment as to why you might be seeing some shifts in diagnoses. The other thing, too, you have to keep in mind is that insufficient alternative services, the old expression, if you only have a hammer, everything is a nail. I mean, there are some kids who are not getting services anywhere, and you suddenly find out there is a program available for kids who have attention disorder, but nothing else. Well, you do get situations where somehow those 3 or 4 symptoms tend to get increased in number and severity such that now a child is diagnosed with attention disorder. But I'm sure that doesn't happen very often, but it's something to keep in mind. Most people grow out of ADHD. ADHD is a childhood disorder. Okay? And this is an important one because what oftentimes happens, if you have a fairly active, let's say, 4-year-old and 5-year-old and 6-year-old, and you're a little bit uneasy about diagnoses and treatment, which is just fine and natural, and that's okay. But if you hear things such as, well, don't worry, he'll grow out of it, or she'll grow out of it, and that won't be as hyper in a few years. In actual fact, we'll talk about is that by the time a child hits about 9 to 12 years of age, you generally see a major shift in the amount of activity they show just over time. And often it's the case that people look at that and say, see, I told you, good we waited, because now he's no longer hyperactive. Okay? And as I mentioned before, If you're just focusing solely on that hyperness, the hyperactivity, then you're going to probably misinterpret the shifts in the symptoms here. You may have an individual who may be still impulsive, but their impulsivity is not now shown in the behavior of jumping here on the table, moving over here, going from one seat to the next, can't sit still long enough to listen to or read a book and so forth. You're now getting that decreased a little bit, but the child may be sitting there and still their impulsivity now is shown more internally. Their thoughts are here, there, and everywhere else but at the task. So that's not to suggest that individuals don't move out of this and don't lose the symptoms. For sure, that's the case. But don't use that as the sole indicator that, glad we waited. You see, they said he's going to grow out of it, and he did. Because if hyperactivity is your only marker you're using, you're probably going to get misled there. Okay? Just to sort of illustrate that, if you look here, and just again, this is just conceptual framework. The average kid, basically most kids in the 2 to 6 year range, preschoolers, are pretty active kids. Big surprise. But that's why there's a great difficulty in doing formal diagnoses of kids in 2 to 6 year range, because the average kid is fairly active. So how do you figure out this kid's much more active significantly than the average kid? It's very difficult. It's not saying it can't be done, because Dr. Bott and I and others have actually published some research showing that you can distinguish them, but it's not an easy task, but you can. And some of the kids we've seen between 4 and 5 years of age are fairly active by the time they get to see us. So, but by and large, you get, say the kids are pretty active, let's just take hyperactivity. By age 4, 5, 6, they're pretty active in general. Then about, again, it varies, but 7, 8, 9, 10, and so forth, you get kind of a drop down. It's not that say that you don't have days and so forth, but on average, you get a general drop down in the overall activity. Teenagehood, kids get a little bit more impulsive and active anyway, even if they have no other problems other than being diagnosed with teenagehood. And so they continue on for the first number of years, and then that drops down into late adulthood, early and late adulthood. If you look at the individuals with ADHD again, you can find a little bit of discrimination on some kids, but on average, it's pretty hard to find it. What you generally find is about, you see the gap right here around the 8 to 12 range, is that this is when kids are actually in school. And so they're actually they're in a situation where there's high demand placed on their ability to stay still, a higher demand to do independent work, to stay focused, etc. That's why it starts to come out around right here. Okay? And so you start seeing that gap. They continue a little longer, but they too drop down in the activity. Oh yeah, so there we go. We say, oh well, he grew out of it. You get a little spike here, but again, that's a normal adolescent issue. But the impulsivity for those kids is a little bit higher, we'll talk about later, and then it drops down. But you get this gap here is because these kids become more distinguished, is that when the situation presents itself, they can't sit still or they can't stay focused. Okay? The kid who doesn't have the problem recognizes the classroom setting, recognizes they got to sort of pull it together to stay a little bit longer, to be able to stay on task, and when they can do it, they recognize and they can do it. There are kids who have attention disorder, given the level of impulsivity. Some don't even recognize that they're supposed to calm down a bit and stay focused. Others actually recognize it, but they can't do it. And that's the whole issue that distinguishes individuals who have attention disorder. You get to the point they understand what they're supposed to do, they just can't pull it back. They can't apply themselves at that time. Just to sort of emphasize again this idea of the developmental shifts in the symptoms, okay? And we'll just take the hyperactivity in the gray, impulsivity in the blue, and green for inattention. What I'm talking about here is that if you look in preschool range here, the bulk of the behavior you're seeing, or the concerns and symptoms, would be the hyperness. The kid is jumping around, bouncing around, and so forth. We all know that type of child, okay? And as I mentioned, though, keep in mind is that if you're just thinking that, okay, we're watching for that and it changes over time, don't use that as your only marker. When you get into between the preschool and the child range here, you see that the inattention becomes more noticeable. Well, why? Well, you're expecting more from the child who starts grade primary, grade 1, grade 2. That's why it becomes more prominent. It's not suddenly that inattention now has become a problem. It's just that tasks that you do in a preschooler don't demand the attention that you do in school, that's all. Okay? So it's the situation that actually draws out the skills that are needed. The impulsivity is there, and then the hyperactivity you can see starts to drop down in terms of its overall presentation. Some of these kids start to drop down the activity level, but now it's much more clear that their inattention, their impulsivity is starting to show more clearly. By teenagehood, it's less the hyperness as much as the overall impulsive say things, do things that you didn't really kind of mean. And also inattentive, just can't stay focused. Start the homework, you got 2 hours of homework, or 1 hour of homework, up and down, got to get the glass of milk, got to go to the bathroom, got to sharpen the pencil. So every 1 hour probably has 15, 20 minutes of work. 1 hour has been put in, but what work has been done during that time is the difference. And that sort of holds when you get into the late teens and adulthood, where, again, most adults have suppressed that hyperness there, although you get the foot tapping and the twitchiness and all that kind of stuff for some individuals, but it's less apparent than running around the room. But the impulsivity and particularly inattention becomes a problem. And individuals who have significant attentional problems, say in adulthood, have difficulties. They have all the intent and set out to do the work. I saw an individual a number of years ago, an executive who had a very demanding job and did it very well. But what normally should take 2 hours of work took him on average 6. He got it done and did it well, but 6 hours instead of 2. Worked for a while until he had a family, and then it caused major ripple effects, as you can kind of imagine. So every 2 hour amount of work, he's doing 3 times that in order to keep up. It's a serious problem. If you think about the percentage of individuals who maintain the diagnosis, let's just leave it childhood as suggesting that, let's say you got childhood and you have all these individuals who have attention disorder, just alluding to what I said before. Of that group, about 70% may continue to show the symptoms and meet the criteria into adolescence, and then a smaller percentage of those will go in, 60-70% into adulthood. Again, that doesn't mean that all these individuals seek active treatment for their attentional impairment. As we'll talk later as well, you get individuals who actually, as they move on, they have choices, and so they actually pick activities, jobs, and other things that actually match their style. As I alluded to this before, once you take medication, you have to take medication for good. This is an important one because most individuals, when you go see a professional, they'll talk in that way. The problem is that you have quite a bias. Most of the professionals will tell you that they actually do, and they're quite accurate, saying our own clinical experience is that when I put a child on medication or recommended they go on medication, they've stayed on medication or need to stay on medication from that point onward. The only problem is that if your treatment approach is that you're going to hold back on medication as a treatment option until the very last opportunity, chances are you're actually only using that treatment for the most severe cases. And as such, it's not surprising, therefore, that individuals who go on medication, generally if they're the severe cases, they're going to need to stay on medication. So you make a little bit of an error there to suggest that go on medication means you're going to have to stay from that point onward, or should, because your starting point is that I'm not going to use that medication as a treatment option until much later on. Okay? So in a sense, you're reserving the treatment for a certain sect of your population. So it's a bit flawed then to infer that the medication, once you start it, you got to stay on it. That's not necessarily the case. As I mentioned earlier, the vast majority of individuals take medication for less than 2 years, and we'll just show this graph again. Later years, the symptoms can be masked to some point by a good match between the profile and the work setting. As I say, individuals who actually find a good match with their style, their ability to sort of handle things simultaneously, need to sort of get things done quickly and move on. If the environment is good for that and supports them, you may find that they know they have these kind of symptoms, but they can work with it just fine. Again, just to show back at that figure again, what we're talking about is that contrary to the impression one might get in the press, is that the vast majority of individuals do not actually continue on a medication for, from the point of onset to throughout their adolescence or even into adulthood. And there's a substantial number of individuals who, even though diagnosed, don't even bother with the medication. So again, it's that when you hear the suggestion of the large number of medications being given out there, prescriptions, just take it and think about it for a little bit. I'm not suggesting that anybody who brings it up as a warning flag should be discarded. I think it's very important to be thinking about that. I'm just simply saying that just pull back a bit and analyze what information they're talking about. Ritalin, I just picked Ritalin as one of the examples of the medication, makes you a zombie. Well, that's a bit of a problem because Ritalin is a stimulant. It's not a depressant. So it's pretty hard to make you a zombie. Again, I just want to make a comment is that if you have questions about medication, you need to talk with your physician about it. But in general, if you're into a situation where a child is showing significant suppression of behavior across the board, and child seems almost unclear and unfocused and unable to concentrate, and they're on medication, it may well be that they're either on the wrong medication or they may have a difference in dose that needs to be looked at with the physician. Oftentimes, you'll get a child, if they're on too high a dose, you actually might get a lot more of fidgety, irritable behavior like biting fingernails and agitation and so forth on these types of medications because they are the stimulants. And you need to keep an eye on those things because there are individuals who get placed on a fairly high dose of medication. And I think it's fair to say that, and this, as with any kind of medication, but particularly these types of medications, is that the individual response can be quite variable. And for example, there's some adults who will be on a medication dose that would be lower than a 12-year-old because that medication, that dose is just enough to actually, in a sense, attach to the cognitive processes of the adult to be able to keep them focused long enough to continue on and use their other cognitive skills. So medications need to be looked at very, very carefully when you're talking with your physician. People talk about the affect behavioral change of the Ritalin. In actual fact, most studies will show that the behavioral change of the reduction in the hyperness and so forth is actually secondary, not the direct link to the medication. So that the medication gets in there, allows you to focus longer, so you're staying longer at the task, so therefore you're not jumping from one task to the next. So therefore the behavioral and hyperactivity and the move from task to task is actually secondary, not primary or directly linked to the medication. Tens of thousands of prescriptions each year. That's true. There's a lot of them out there. You just had to be, again, aware of the fact that Ritalin and other psychostimulants are classified as controlled substances. So in that case, you need to have, from your physician, the prescription has to be done in triplicate. And typically, it's a 90-day prescription, so that if you're trying to get yourself through a full year, individuals have to go back and have, say, you'll have four different times when there's a prescription made. Right? So that's the reason that's important is that if someone goes in and has a prescription for another drug, let's say for allergies or whatever the case might be, there may be a prescription made for the entire year that you can go back and you have like 4 or 5 refills or more than that. But with these kind of controlled substances, the problem is that you actually can't, generally speaking, unless there's some variations and some exceptions, but generally you can't do that. So in a sense, what's recorded on the system is that there have been 4 prescriptions made that year, just by one individual. So that's, if you multiply 4 times that one person, then there's 10 people, that's 40, etc. So I'm just giving that as an example. When you're trying to interpret these numbers, when people throw out numbers and say, look at the total number of prescriptions written, you've got to be aware of the fact that actually the pattern of prescription writing for controlled substances is different for other types of medications. I'm not suggesting, again, that it's not an issue to be concerned about. Just make yourself aware of the fact that where these numbers come from and how the calculations are made. Too many kids are over-medicated. That's a tough one. I think that basically, as I go back to the point that few kids stay on more than 2 years, and again I talked about the prescriptions as a total is an inaccurate index, okay? That's not to suggest that some kids are actually medicated when they shouldn't be, or they're given too much medication. You do need to be aware of that. I've seen kids over the past number of years, some very notable cases where kids are on a remarkably high dose of medication. And we can go into that in discussion later, but there are cases where if you're just looking for a reduction, let's say, in the hyperactivity, and you're not getting it, and your approach is to keep just increasing the dosage, that could be a bit of a problem. There may be other disorders going on simultaneously we'll talk about. Then, in a sense, if you think there's only one disorder going there and you're trying to treat that one disorder and it's not working well, and so you're still in the mindset that it's only one thing going on, so the only approach is to keep increasing the dose, that's a bit of a problem. So you had to be quite knowledgeable of that and be aware of it. In the last number of years, there's been an increase in the number of females diagnosed and medicated. Okay? One thing I'll comment about that is that oftentimes you get referrals later for females. Let's say the average boy gets referred at 7. You may have females referred more about 9 or 10. Parents are getting to the point that the kid's never been hyper, but they just seem to be sitting there and taking it in but not taking it in terms of the classroom and so forth. And these individuals may have just a pure inattentive disorder. And so there's been an increased awareness of that, and so there's been an increase in the number of diagnoses and medication given there. As I mentioned earlier, there's been an increase in the number of adults who've been diagnosed and medicated. And again, those diagnosed without medication, but there's been a greater increase in the diagnoses for the disorder, partly due to increase in the females, partly due to the increase in the number of adults as well. So basically, I think the key thing to keep in mind is that when you look at total numbers, just pull back a bit and say, well, where is this coming from? And there are reasons why there's a total increase, but again, you should be aware and again be concerned if you feel that it is getting a little bit too out of hand. But again, I'm just suggesting you back up and look at where these numbers come from. Try to figure out what are some of the drivers that might increase those statistics. An example here about the number of individuals on medication, if you take 6 to 11 years of age, these data from the Center for Disease Control in the United States, basically kids who've been diagnosed with attention disorder, about half of them are on medication, half of them not on medication. Okay, these are rough figures. Individuals who have combined attention disorder and learning disability, about 60% of kids will be on the medication. Okay? And we'll talk a little bit about the link between those two things in just a little bit. So the key thing is that just because there is a diagnosis made, it doesn't mean automatically, therefore, medication is being used. Too many kids diagnosed, we kind of alluded to that already, I guess. But again, the key thing is if the kid's properly diagnosed, then that does make a difference, as opposed to if you just have feedback from some individuals that child's got a problem, and then you go ahead and if someone's going to basically recommend that you go ahead and have a diagnosis made immediately and have treatment option number 1 as being medication, I think you want to go out and get a second opinion. Okay? Because a diagnosis of attention disorder takes a bit of time. It takes monitoring over a period of time to make sure we're not dealing with other factors that are influencing the child's behavior. How long has it been occurring? Has it been with the child in some form, whether hyperactivity or impulsivity, back when the kid was preschooler, or whether the child was in grade 1 or 2? Are we suddenly seeing attention disorder suddenly popping up now at age 10 or 12? You need to find out whether there's other things going on in the kid's life and so forth. There's a lot of factors that need to be kind of put aside to make sure you're dealing with that particular disorder. Kids don't have attention disorder, they just have learning disability. Well, they may well have a learning disability, but they can also have attention disorder. Okay? The combined diagnosis of attention disorder with learning disorder, 30 to 40%. If you go through another variety of studies, you might find it less or a little bit more, but the rule of thumb is about 35% or so of kids who have one disorder, say a learning disorder, may have the other and vice versa. The reason that's important is if, for example, you have concern about your child, your patient, if you've got a 35 to 40% overlap or coexisting attention disorder with learning disorder, if you're going to get a child assessed and looked at, you want to make sure you get both looked at. Okay? Because you're getting close to flipping the coin there. So it's important, for example, if you say, I'd like to get the child assessed for learning disability, that's good. If that's your primary focus and that's where you think the real issues are, that's all right. That's good. It's a good guess and good starting point. But you might want to also back that up with at least screening for attentional problems. And then the reverse. If you think the child is predominantly, oh, he's just hyper, doesn't have any trouble learning, he's just hyper, he just needs to sit still long enough and focus. Well, that may be the case. You may well be right. But it'd be good then to assess more heavily on the attention disorder, but then secondarily, simultaneously, you want to screen for a learning disability. I just checked to see if you're paying attention. That moves very fast. This is the one I love the most. It's not ADHD. He did fine yesterday. He just needs to be more consistent. And my take on that is that the most consistent feature of attention disorder is inconsistency. And that is really the case because kids get burned on that one numerous times. Okay? The moon and the stars line up, and it's a great day. They get 85 on that math quiz, and they go, look, I told you could do it. Thursday, 61. Friday, lucky to get 31. Okay? And so you say, see, you're not trying, you're not motivated. Being able to do that kind of work is not the same as riding a bike. Okay? We sort of mix that up a little bit. We think, give the bike, keep the roadway somewhat clear, and let the child go ahead. The issue is that when you have attentional impairment, you can't pull it together on an as-need basis all the time. You have trouble pulling it together for that moment. That's one of the key things that distinguish individuals with attention disorder. Okay? On a good day, they can pull it off. And then we're always saying, see, I told you. And we think we're actually giving lots of reinforcement, which we are, I suppose, but we're also putting the gauntlet down and saying, I don't want to see this bad performance that you had last week again, because I know now you can do it. We keep thinking of it as an ability that can be repeated anytime on demand. You might be able to do that with some things, but you can't do it with attention if you have attentional disorder.
So should we be putting the referral in early, or should we do it in school, or allow them like when they go to primary, they're like, well, it's still we need to medicate?
Well, we can talk a bit about that. I think it all really depends on the severity of the presentation. The kids that are early on in preschool, the vast majority of kids don't go on medication. We've seen kids historically who've gone on medication, but these are fairly, these kids would definitely stand out from the average 4, 5, 6-year-old. Okay, these are kids who we have had concerns about their own personal safety and the like. And so you've tried behavioral approaches, and even with a high degree of supervision and very strict behavioral strategies, the impulsivity is just so overbearing. It just wasn't doable. What is to say, you might be watching to see how things go in grade primary and try to get a structured program going. And then if the behavioral approach is not working, but you want to make sure that you review the behavioral approach. You don't just sort of put a behavior program in and then say, well, gee, look, we tried that behavior program for 3 weeks. I guess we need to go get some medication. That is a problem nowadays, I think, because teachers and schools are under a tremendous amount of pressure when they don't have the resources. And so the shift and say, your kid's got a problem, let's go get him medicated, that's a bit of a difficulty. You should be looking at how you can try to resculpt the environment a bit, trying to get contingencies there, try to actually keep the kid focused and have closer monitoring of the behavior. And if that's done over a regular period of time, extended period of time, in a consistent manner, and you're still getting the concerns, then you want to be looking at other types of interventions. But the consistency of behavioral approach is probably the best thing to be using for the kids going into grade primary, except for those very exceptional cases. Russell Barkley said it well. We had him here a number of years back, and a child has a good day, and we hold it against him for the rest of his life. And really that is the whole point, is that you're telling a kid that we know you can do it. I'm the adult. I know. You see what you did today was great. But so you're putting up a pretty high marker for someone who's not able to actually sustain that. How can she have ADHD? She can watch videos or TV for hours. Don't get me started on that PlayStation. Well, the issue is that, and that's why maybe attention disorder actually is a bit of a misnomer to some point, is that video and TV are very passive activities versus doing homework. Doing homework, you have to sit still. Doing homework, you have to actually process the information. You got to reflect on it. You got to use your memory. You got to pull information from other sources to make the calculations, et cetera, et cetera. Video and TV, you sort of sit there and watch. Okay? And you're not doing anything. You're not expected to do anything. You just sort of just sit there, which is okay. But it's a passive activity. So to say, because you can attend in that situation, you don't have attentional problem is not very fair. PlayStation or computer games, you have immediate contingency. Those games are designed to have high amount of attention-getting material. You have almost instantaneous feedback if you press the wrong button or you make the wrong move. Where else in your environment do you get that kind of feedback? So it's a fairly artificial environment. And if you see kids now, they download different games. They're under headings of, for example, addictive games. I think that's a pretty good title for some of these websites. Some of these games are pretty addictive. So the But these games are very different because they give you immediate feedback on your behavior. So because you can stay focused for a video TV or with PlayStation, don't use that as mounting evidence that the child doesn't have attention disorder. Usually when I talk with parents and we do an interview, I say, other than these things, video, PlayStation, Xbox, put that stuff aside. Let's talk about his behavior in other circumstances. And they keep going, no, I don't want to talk about this. What about the behavior outside these? Because this is not going to help you in terms of doing a diagnosis of attention disorder. Mind you, if you can't sit still long enough for the video, TV, and PlayStation, I think you probably do have some things you want to look at. But the vast majority of individuals can actually pull it together for those types of activities. Only medication works for ADHD. That's not true. Depends on the type and intensity of treatment, will depend on the type and severity of your attentional problems. Good behavior therapy, cognitive behavior therapy, the difference there is that as you get a little bit older, you're able to sort of plan ahead, evaluate a situation, talk yourself through, etc. So cognitive behavior therapy and medication, those are three sort of basic treatment approaches that can work, but it depends, what you need depends on the severity of your attention disorder. One way to think about it is that if you have a mild problem, again, this is just conceptual, okay? But if you have a mild symptoms of attention disorder, the behavior may well be just enough. You got to keep on it. You got to use timers. You got to have very close monitoring, checklists, reinforcers, et cetera, to stay on task. But if you have a mild problem, that might be just enough to kind of pull it in. If you're in the moderate degree range, it depends on your age, depends on what the activities are and so forth, but you may have to ranch up a little bit the behavioral approach here. And then generally when you get into older individuals, you need more of the cognitive behavior. The cognitive behavioral stuff doesn't work that well for the younger kids because you're expecting them not only to just be less impulsive, you're getting them to stop and think and walk through their strategy. Most 6-year-olds are not doing that. So the cognitive behavior approach is usually for a little bit older kids, 10, 12 years. It can be younger, but it depends on the individual child. And then for older individuals. When you're into the severe range, what you find here is that if the impulsivities we talked about before is so pressing, it's so omnipresent, that even if you're trying your behavior program, the impulsivity is so evident there that the behavior program, it might work, but it can't get a chance to work yet. You need to, in a sense, the medication is there to take the edge off the behavior. Then you start with the behavior program. It's not the case that you ever use medication and no behavioral stuff. Okay, and that's why there's a serious problem out there. People think, oh, we'll go to medication so we don't need to do the behavioral program. Very, very bad move. Okay? The best outcome for individuals who have significant attentional disorder is the combined approach of medication and behavior. For kids who have less symptoms or have less severity, the behavioral might be enough to pull them through. But you need to keep monitoring it. It might be, for example, the mild form of the attention disorder is such that the behavioral strategy alone works for age 6, 7, 8, 9. Now you find that the workload and other things are coming in. The inattention is more the issue. Kids still can't stay focused even with those other behavioral strategies. Maybe you need to shift and add medication onto that. But again, it's just monitoring, reevaluating as you go along. It's not an all or none, medication, behavioral, etc. But if you go to the medication, you don't drop the behavioral. You don't drop the behavioral. What you do find sometimes is that individuals, when they make a shift to the medication, what I have found is that you get big effects initially if it's appropriate to give the medication if the child responds positively. Problem is that people then put their guard down and they don't realize they've actually dropped back on the behavioral approach that they were working at, say, 3 months ago. The difficulty there is that the first response is, oh, well, we need to just jack up the dose. So now you've stuck, now that you moved here, you stick with that as your only intervention. If you're going to move to medication, you should always be doing the behavioral simultaneously. You have to remember that if the child has a significant attentional disorder or adolescent or adult, you're just simply trying to stay with the medication enough to get them up to a level playing field. That's all you're doing. You're trying to get them back up. Any child who has no attentional problems still needs a good structured environment, right? So there's no different here. If you've got a severe enough problem, you're just simply using medication to move yourself up to have a level playing field. That's all. I mentioned basically in terms of the treatment approach, the behavioral. With the younger child, you're probably needing to be more omnipresent there, using very strict reinforcers and timers and so forth. For example, bedtime, you could be using things like beat the clock, so you get a little countdown electronic timer from one of the stores around town, and so the child actually gets a reward if they're able to get their teeth done and their face done before the timer goes in 2 minutes or something. They get a star for that. They get another star if they're within 3 minutes before the timer goes to get themselves in their pajamas, et cetera, et cetera. Morning time is also a tough time, so people using timers, other types of reinforcers are worthwhile strategies, and those are examples of the direct behavioral approach. Doing homework, doing sort of things like study bursts, 5 and 1. Have your timer, kid works for 5 minutes, takes a 1 minute break. 5 minutes, 1 minute break. 5 minutes. So for each 5-minute interval that they finish up, you get them a star, and at the end of it they get 5 stars. Maybe they can go play their PlayStation or whatever. But those kind of strategies, those are the basic direct behavioral approaches that you're working with these kids. When you move into adolescence and so forth, the more cognitive behavioral, you're getting them in, starting to use Palm Pilots, or you're trying to get them to use note-taking, other types of strategies to keep themselves on task, using reminders and so forth. One of the biggest problems I find in individuals in adolescents and adults who have trouble with attentional difficulties, they say, I'll write that down. They're looking for a piece of paper, a pencil. Oh, well, I'll remember. No, you won't. So what I suggest is, and now it's even gotten easier, a lot of electronic stores and so forth have these little dictaphone things. They're about this size or even smaller now and thinner, and you just simply give yourself a note, because you don't have to find the piece of paper, the pencil that you're going to lose or put in the wash. So you just sort of pick it up, and then you say, okay, I need to be at Jim's at 3 or something like that. And at the end of the day, you can sort of play them back. But they're getting fairly inexpensive now. The issue is not so much the electronic push as much as the ease with which they can be accessed. Because even the most well-motivated individual, for someone who has an attentional problem, this little gap between access to making the note is just enough for the note not to be taken. It doesn't matter how motivated they are. So that's when you get into the cognitive behavioral strategies, walking yourself through. Okay, I know I got this. Example, I saw a young fellow recently, he's 21, 22, and essentially he shows up at every appointment a half hour before. Greatest patient you can have. I mean, he shows up at half hour before, and he's sitting there. He's anxious, ready to go, and so forth. He's looking at the watch. He's got to actually turn himself into be somewhat obsessive about time, because he's spent so much of his life being late for things and being criticized and so forth. He's made a concerted effort to get himself in on time, but he sort of shifted a little bit to the obsessive part. I don't know if some of you remember John Cleese movie about someone being obsessed with time. This guy had it, but in a sense, he's aware of being a bit obsessed about time, but he finds that easier to manage than getting the criticism for constantly being late. So that's where the cognitive behavioral strategies sort of come in, keeping good schedules and so forth. Again, just thinking about it this way is that there's a heavy genetic influence. If it's a mild enough problem, behavior is just enough. Maybe the behavioral aspect of it, if it's a mild ADHD, might be enough to take care of the problem and keep things suppressed, at least for a reasonable period of time. If you have a more moderate problem with attention disorder, the symptoms, you might have to retch up the behavioral approach to be much more vigilant, not letting too many gaps occur in the day, keeping on somebody on a regular basis. But when you get to the moderate level, and then also moderate severe range of attention disorder, you need to keep these, but you then may have to look at medication. ADHD is not really a disorder, it's just a misdiagnosis of some of the other problems. Well, in actual fact, the reality is that comorbidity or coexisting of disorders is more common than not with individuals, let's say, who have attention disorder. The problem is that some people look at the predominant presentation of somebody, and they're trying to put it all and fit it into one basket to explain everything. And that's not a good approach. Again, the numbers, don't get too caught up in them, but on average, 20 to 30% of individuals, and say some studies show that I showed earlier 35 to 40%, depends on the study, but say on average about 35%, kids will have attention disorder, will also have learning disorder, or the reverse. The reason that there's a lot of variability in this particular group is that the definition of learning disability has evolved notably over the last 10, 15 years. And there's a lot of changes in criteria, so it's hard to make comparisons across studies. Again, I guess the point to keep making is that because you see variation in the percentage of individuals identified, it's very easy for some folks who are against the diagnosis to take that solely as a way to say, gee, that's not a real diagnosis. You have to go back and say, well, why are they having that variability? Well, the diagnoses and the criteria for learning disability has changed somewhat. Well, so has that for ADHD. So that can greatly affect whether you're looking at a study that was done 5 years ago or 8 years ago versus today. ODD is oppositional defiant disorder. Basically, sorry. I'm not sure if I know how to go back here. ODD, or then we have cognitive disorder. Again, there's a high percentage of individuals who may show that as a comorbid presentation. Kids who have oppositional defiant approach and behavior may go on to actually show significant problems with their behavior such that it develops into more of a conduct disorder. If you think conduct disorder, really you're getting into the point of more sustained difficulties in your behavior. You're violating laws, you're violating the space and of other individuals around you. Altercations with the law and so forth may unfold. But that's not, when you look at ADHD, people say, oh, well, gee, this is what's going to happen. There's a lot of factors that go in to actually determine whether you're going to evolve into having that much of a significant problem. But again, comorbidity is not an uncommon feature. Anxiety and depression is also found. Anywhere from 20 to 36% individuals can have anxiety and depression. Sometimes, for example, you'll see adolescents or adults who have never been diagnosed with attention disorder, never been treated, have secondary depression because they're depressed about the fact that they keep making strong commitments to do things and they never get them finished. They're feeling badly about their lack of performance and so forth, and so you may have secondary depression developing. But you can also have primary depression and coexisting depression along with attention disorder. Just as a couple of key resources if you want to take a look at, there's a ton of books out there. The ADHD report, Russell Barkley has this out, and it's generally a reasonably good summary. There's a lot of research that's actually put out there, keeps things up to date. There's reasonable critiques. It's fairly balanced at times. It doesn't take a particular orientation, so it's not a bad periodical to take a look at. CHAD, which is the organization, there's a Canadian version as well, Canadian website. Just simply, Google that, and CHAD provides a lot of information out there for access about diagnoses, about treatment options, and so forth. I apologize for the lack of focus, excuse the expression, on the slide. But basically, this particular site has a lot of information there, but there is a Canadian version as well. There's also another website, actually, I don't think I've listed there, but some of you are familiar with Charles Schwab, the investor. I'm not making a pitch for Charles Schwab, but basically, his son was diagnosed with a significant problem with learning, and himself with a significant learning problem. He found out late in life, and he's put a remarkable amount of money into support educational services about learning disorders and so forth. And they have an excellent website that's kept up to date on a regular basis, so you might tap into that as well. It's the Schwab, I think it comes under schwablearning.org or some such. You can just take a look for that. But there's a lot of good tips there, examples of what you can do to improve the homework time and other types of approaches. Barkley has attention deficit disorder, deficit hyperactivity disorder. This handbook, there's a newer one out actually. It's coming out this year. So there's an updated version of that. That's with Guilford Press. And that's kind of a pretty heavy book to slog through. So, but he does have one, the previous one I showed you about the handbook, about what you need to know, taking charge of ADHD. I think there's a recent version of that out there. It provides a fairly good overview without getting too heavy duty in some of the, this study, comparative of 3 studies and so forth. If you want that, then you can go to the heavier text for sure. They're not trying to suggest you don't have the ability to go through that. It's just that you might want to go through, say, something like this first, and then if you want to get more information, dig deeper, the other authoritative text would be something to think about. This book actually is a really neat one. It's for Parents and Teachers is a guide to basically solving problems for kids who have attentional problems, students who have attentional difficulties. And it's designed predominantly for the elementary and secondary students. And it's by Dr. Parker. He's written a number of textbooks out there. This is a fairly recent one. And there's a lot of great little tips in there about how to help you through and walk through homework time and set things up. In a sense, what you're trying to do is set things up for success. And this particular book, I think you might find pretty helpful. That's it. So I'll open up for questions that people may have.